everyone. My name is Brad Gross. I'm a neurosurgeon at the University of Pittsburgh, and it's my pleasure to talk with you about our experience with the React aspiration catheter. I am a consultant for Medtronic and microvention. And looking back at our experience with aspiration catheters at the University of Pittsburgh, a few years ago, we had a publication that compared a similar cohort of aspiration catheters, the CAT6, the A68, a 6 French 072 Navient, and a Sophia that were used for aspiration thrombectomy. And the concluding findings of this paper were simply that aspiration and reperfusion results, as well as outcomes, were effectively similar between these two catheters, meaning that one can essentially pick any, perhaps one that is most cost efficient for their respective center to use, was our essential conclusion from this study. Now, following this cohort of 060 to 068 aspiration catheters, a new concomitant group of aspiration catheters were developed by different companies that came out, and we evaluated our first 50 cases with them. This included the React 71, the Vecta 71, and the Jet 7. We found overall fairly similar reperfusion results, but fairly improved navigability for the React 71 and Vecta 71. We also had very nice reperfusion results as well. When looking at being cost efficient about doing thrombectomy, we evaluated the importance of capitated pricing models. Germane to the React catheter, we found considerable cost savings when we bundled the React catheter with the Marksman catheter, now the Phenom 27 catheter as part of that bundle, as well as with the solitary revascularization device, which is part of a useful bundle that we now frequently use. But having accumulated a reasonable amount of experience using the React catheter, we wanted to look at this more formally. So just to talk about my personal experience first about using the React catheter, at the time that I was putting together this talk, I guess I had used it 131 times. I was previously an A68 user, and with A68, I had used it 79 times, had a respectable TICI2B or better result of 91%. You could see some of the other catheters that I list there that I also relatively frequently use. In the cohort of patients that I treated with React, the mean age of the patients was 69. There was a reasonable proportion of octogenarians and even nonagenarians. Overall timing of the procedure was 25 minutes. About 2 passes per procedure was the median. A fairly expected distribution of clot locations involving the M1, ICA, and basilar, including a decent number of tandem lesions. The TICI2B or better result in my own adjudicated hands was 94%, and complications were relatively sparse, fortunately, in my own experience. This is just an excerpt from a paper that shows that we achieved reperfusion in about 4 minutes time for an M1 occlusion using the React catheter. Here's a looping video that is demonstrating how easy it is to navigate over simply an 027 catheter into the M1. This is a really nice allure for this catheter in my own experience and hands. In this slide, you can see that we are looping an aspiration result. This is through an 088 catheter that is parked at the high cervical ICA and then loops into the Petrus ICA as the React is withdrawn, maintaining good access. And you can see just this anecdotal example with a nice reperfusion result. My personal observations about the React catheter that I personally like a lot is that at times you can actually advance it free without the microcatheter or wire. It's so supple that it can actually navigate around the siphon, even into the M1 free without a microcatheter or wire. But what's nice is that when you make these turns or when you withdraw it, you don't lose the aspiration force because it doesn't kink or lose its full OD around those more difficult turns, which is important for aspiration efficacy, in my opinion. In addition, simply, it's a rugged catheter, I guess is a nice term to use. It can be reused frequently. It doesn't break or get gummed up when you take it out of the hoop. It is very compatible with any stentriever, which is really nice. So if you deploy a stentriever and like to do the technique where you completely engulf a stentriever by advancing an aspiration catheter, the React is ideal for that. It continues to maintain its aspiration force after that, which is very important. You can do runs through it, and nicely it doesn't blow apart on you. I really had, in 131 cases, I haven't had any unusual events with React and have regularly reused it. As part of our bundle, which is a nice cost-efficient opportunity that we have, we utilize the React with the Phenom 27. Phenom is well situated and designed for strokes in particular because of its 160 length. Very importantly, since we do strokes under IVCS, it is a very visible catheter. And it's also a catheter we're all familiar with since we deploy pipelines through it, a very commonly used flow diverter. It is very compatible with the React with an acceptable ledge effect. I do not find that I get trapped on the ophthalmic as I'm trying to advance the React over the phenom. And I also don't need to use a large microwire. So sometimes some of the moves that we make to get these large bore aspiration catheters up is to use ON8 or larger wires, which are now becoming an option with more advances in these larger wires. However, a simple 014 wire is really all you need to get the React up over a phenom around the siphon towards your lesion, and certainly for the posterior circulation, which is easier. And importantly, again, it is very compatible with the React catheter. The solitary vascularization device I really like to use. I think it's very supple around terms. It has good length to it, and it nicely intercalates with the clot. It is an excellent anchor to advance the React catheter, and so it works very well with it. As I said, it's very compatible with React, although I've used a variety of other stent treaters with React as well that don't gum it up at all. But I do like advancing the React over the solitaire. I think it holds its anchor position well and allows you to bring the React up into the M1, even into the M2 if need be. However, quite frankly, everyone knows that self-adjudicated individual experiences don't necessarily have very good external validity. People can make up their own 2B, 2C, 3 grades, and really single arm studies are really a matter of opinion. So in our institution, we thought it would be more interesting to do a comparative analysis where we took our institutional data, so a little bit more external validity with more users, and then compare it to our previously most commonly utilized catheter. So this was recently published in the journal Neurosurgery. And what we did was we collected our first 150 institutional cases using the React 71 aspiration catheter. The mean age of the patients was 71. You can see demographics are as expected, about nearly a third got TPA. Lesion distribution involved the ICA and M1 the majority of the time, sometimes the M2 or the basilar. And in this arm, we adjudicated TICI-2B results of 95%, TICI-2B or better, with 47% of cases actually being single pass simple cases. The mean number of passes was 2.2. What we did, though, is we went back and compared it to a competitor 068 catheter that was a frequently used aspiration catheter previously. And so we collected 96 cases using that 068 catheter. And in those 96 cases, you can see that the cohorts are relatively well matched, with the exception that there happened to be more females in the 068 catheter cohort, and there was slightly more TPA administration in the 068 catheter cohort as well when you review this table, the upper part of the table. Index clot location was overall similar, with the exception that we did more basilars in the 071 group, which may potentially portend a worse prognosis, which is relevant. However, in the end, when we looked at the rate of TICI-2B or better reperfusion, there was no significant difference. The problem is that with adjudicated rates of 94, 95%, it's going to be hard to demonstrate a significant difference between these two catheters. So we instead tried to look at parameters that better delineated aspiration efficacy that could potentially demonstrate a difference. So when we looked at single pass case frequency, with the React 71, that rate was 47%, as opposed to the prior, previously commonly used competitor 068 catheter was 35%. And this difference was statistically significant on a multivariate analysis. In particular, for ICA lesions that you might postulate would be better situated to be treated with larger bore catheters, we found that the single pass case frequency rate improved from 16% with the competitor 068 catheter to 43%, which is a statistically significant difference. The rate of TICI-2C or 3 after the first pass was also significantly better. As you can see here, that difference was statistically significant, 26 versus 14%. And the final TICI-2C rate was also statistically significantly better. And again, a single arm TICI-2C or 3 rate of 39%, 40%, 80%, 10%, it doesn't really mean very much. But I do think that if you make a comparison with the same users between two catheters and show a difference, I think that that could potentially be of interest externally as well. And we do find that, again, the rate of single pass cases was significantly less with React 71, and the rate of effective reperfusion, that is TICI-2C or 3 reperfusion in our own adjudication, was better with React 71 as well. So putting this all together, I really like to enforce the importance of strong, effective reperfusion going beyond TICI-2B. So looking at single pass case frequency or first pass effect, looking at ICA lesions that can be more challenging potentially for smaller bore catheters, and importantly, looking at TICI-2C or 3. Again, a single arm TICI-2C or 3 analysis may not necessarily mean much, but when you compare it and see an improvement, I think that's pretty remarkable. About the catheter itself, the React 71 is supple, but doesn't kink around turns, which is ideal for effective aspiration and delivery. It's rugged, it's reusable, it's reliable with any centrifugers, and runs through it are very safe. And it bundles well. I find that it's very compatible with the Phenom 27 and certainly the Solitaire X revascularization device that I like to use. This is just a few illustrative pictures of some revascularization cases. With that, I thank you for your attention. And after this, it's my pleasure to introduce Dr. Amir Hassan, who'll be talking about the Viz AI. Thank you all.
Hello, everyone. I'm Amir Hassan, and I'll be talking today about our experience using Viz AI-powered telehealth in a hub-and-spoke system. Here are my disclosures. So a little bit about Valley Baptist Medical Center. We're in the southern tip of Texas in the US. We do about 12 to 1,300 neuro cases a year, a little over 200 mechanical thrombectomies annually. We have 3 interventionalists now and 3 biplanes at Mothership, and we opened a second CSC as part of our network that also uses Viz. We have a sister hospital that's a primary stroke center, and it had Viz installed initially in 2018 when this study was initially started with Valley Baptist Harlingen. We've been a part of multiple studies, as you can see here. So the current state of mechanical thrombectomy and acute ischemic stroke, as you know, is increased patient volumes have caused some challenges. And there are long treatment times. The paper that was published based on the Stratus registry showed that transfer patients had on average a 5-hour treatment time compared to patients who directly showed up at a comprehensive stroke center, the average treatment time of 3.8 minutes. During this whole thing with COVID, we've noticed obviously significantly increased volume in the hospitals. So there are bed shortages. So the last thing I want is a futile transfer. So we need better control, better understanding, better triage in order to help with our bed shortages and especially the strain on our ICU beds. We all know that there's a significant benefit of thrombectomy per minute saved of approximately $1,000, and there's significant provider burnout. There are too many calls, we're constantly glued to the hospital, and all of us feel very overextended. You all know time is brain. I'm sure you've seen some variation of this figure, but the key thing here is in 1 minute, in a patient who's less than 55 years old with an NIH stroke scale greater than 10, every minute saved, you increase that patient's extra healthy life by 1 week. So a 20-minute decrease in treatment delays equals a 3-month gain of disability-free life. So how do we treat more patients faster and better? And obviously we use technology. We did a lot of research several years ago on something we called Steps T, and that looked at trying to get patients quickly from CAT scan to angiosuite, specifically improving angiosuite to puncture, puncture to recanalization time. But when you look at the big picture of door to recan, that was a very small portion of it. The bigger portion is detection and transfer, especially in patients who approach our primary stroke centers, which we currently have approximately 11 hospitals that transfer into Valley Baptist Harlingen. So with Viz AI, we can focus on early detection, rapid triage, and synchronized care coordination. So this is just an example of the screenshots. This is the kind of alert we get, suspected large vessel occlusion alert as a push alert on your phone. It also gets pushed to your Apple Watch. When you open it, you see this, and this is an example of the CTA. So here you can see there's a left M1 occlusion. You do get CTP images if you had them completed, and if you want them. You can always look at the initial CT head. And then there's the Viz Hub, which is the HIPAA-compliant texting and workflow visualization tool. To me, this is the most important piece, right? This is where my neurohospitalists at the spokes feel like they are the decision makers. They are working with us and everybody's on the same page. So we get this elbow alert. They're looking at sometimes these images even before I do because I'm stuck in a case or I'm doing something else at mothership. And they're like, hey, this is a great patient to transfer. And then the house supervisors on this group, the stroke coordinators at both institutions, the neurohospitalists, ED physicians. So everybody knows what's going on once that alert is pushed and people start messaging each other. So here is the abstract, initial abstract that you'll see was published in Interventional Radiology. Early experience utilizing artificial intelligence shows significant reduction in transfer times and length of stay in a hub and spoke model. This was published, like I said, in Interventional Neuroradiology a few months ago and was initially presented at ISC 2020. And what we found was, so in the end of the day, we need accurate and fast identification and triage of large vessel occlusion. So this is the most important thing. And then using something like Viz AI, you have a stroke detection tool, you have workflow software, and it utilizes AI to automatically identify large vessel occlusion and then alert the on-call teams. Then the on-call teams use that synchronized care communication tool in order to get transfers done faster and not having to wait for CTA reconstructions and radiology reads. Your independent operators can review everything. So we said, okay, let's look at the impact pre and post Viz. So we did have a competitor software since 2013. We were part of Swift Prime, Dawn, Select. So we always had some sort of CTP and CT emailing tool to look at images. Now, moving to this obviously was the first tool where it was pushed to your phone that was approved in the US. And we said, okay, we're going to look at all of the transfers from Valley Baptist Brownsville to Valley Baptist Harlingen, which is mothership, the CSC. And we're going to compare the pre and post Viz implementation. And what we found was starting November 2018 to May 2019, which is the data we could collect so that we could have outcome data to present by the August deadline of ISC, you see here that how streamlined everything is compared to how piecemealed it was prior. Why? Because yes, you got an email about a CT perfusion, but we never got anything for the CTAs. And even if you did, I mean, knowing the software today, it doesn't really give an alert. It just shows you a picture and it gives you color coding. So historically, the workflow was the CSC physician was called regarding a possible large vessel occlusion. The CT angiogram was ordered, but then they had to wait for a radiology tech to reconstruct the images, radiology to be able to read those images. They called the ED physician or the neurohospitalist at the spoke, who then would call us. Then I would call the house supervisor, and then we get the patient transferred. So to make a long story short, this is obviously way too many steps. So we were able to save 66 minutes. The average was 171 minutes in the same time period prior versus 105 minutes post Viz implementation. So we saved 66 minutes, about over an hour. And that led to 55% decrease neuro ICU length of stay, 6.4 days versus 2.9 days. So 39% reduction in time from primary stroke center to comprehensive stroke center. We saw a 55% reduction in neuro ICU length of stay. Now, what happened here? So you had the implementation of Viz AI significantly reduce the time. And we know time is brain, right? So you had patients having better outcomes, staying in the hospital much less often, especially in the neuro ICU, and then shorter overall hospital length of stay. And this is how we brought it up to our CFO and COO in order to really get this implemented in all of our spokes. So patient outcomes we know are time dependent, a loss of 4 days of disability-free life with each minute delay in thrombectomy, 10 days of functional independence. So there is a lot of research in this. So a time savings of 66 minutes from PSC picture to CSC arrival suggests the implementation of Viz can basically add additional days of disability-free life, approximately 265, and additional days of functional independence, 660 days. Now, looking at multiple center data, we showed 66 minutes saved, right, at Valley Baptist when comparing pre and post vis with your transfer patients from your primary stroke center. Dr. Mako and Dr. Fifi at Mount Sinai showed 33 minutes saved, PSC arrival to INR medical team alert, and mean arrival to PSC to CSC puncture, also 33 minutes saved. This data also showed 24 minutes saved per patient. This is actually Colorado data, not Mount Sinai. So they showed that pre versus post vis, significant reduction in time to treatment, reduced door to procedure time. But as you notice, after vis implementation, 100% of patients were within the door to device time of 90 minutes. So very, very impressive data out of our folks, our colleagues in Denver. And the SEMI's Murphy program showed in a hub and spoke model, 44-minute time savings. Again, Don Fry's program showed the 24 minutes with 100% of patients showing getting a door to device time less than 90 minutes. We showed here at Valley Baptist 66 minutes saved from CTA performed at primary stroke center to puncture. And then the Mount Sinai group showing 33-minute time savings. So what does all this mean in the end? It actually does show improvement, right? We all say, yes, we save time, we save 10 minutes, we save 30 minutes, we saved an hour. What does that actually mean? You need to be able to show administrators and to show, we all know we do what's right for our patients and our families, but in order to get things like this paid for, we have to please our administrators. So from our standpoint, showing that significant reduction in hospital length of stay of 2.5 days and neuro ICU length of stay of 3.5 days, this was like, you know, oh my God, we need to really get this installed in all of our spokes because this is a cost to us, especially in this day and age where our ICU is packed every single day since March. We've never had open ICU beds. It's basically just triage every morning. Who are we moving out and who are we going to bring in? The other systems like Mount Sinai showed the pre-vis versus post-vis 5-day NIH stroke scale, significant drop from 22 to 11. Discharge modified Rankin drop from 4.6 to 2.9. And the 90-day modified Rankin dropped from 5.0 to 3.0, all statistically significant across the board. So Viz.AI demonstrated to CMS that the reduction of time to treatment improved clinical outcomes and increased access to care for patients suffering a stroke. So showing at centers 66 minutes saved like at our center, showing the data out of Mount Sinai with the significant improvement in 5-day NIH discharge modified Rankin as well as 90-day modified Rankin, and showing improvement and the increased access to care with 16% increase in patients qualifying for thrombectomy. This, all in conjunction, showed the CMS the benefits of artificial intelligence in acute ischemic stroke, and therefore we were able to achieve the NTAP approval. Honestly, we have had a great time with the software. We've been able to significantly also improve the amount of patients enrolled in our studies, right? Patients who come in from your spokes can quickly be screened using the same tools and the communication. Our research staff is on that Viz hub, and we consistently message each other about what is going on. This patient is a potential for, let's say, CHARM, SELECT2, especially the large core trials. This has been very, very useful. We've enrolled 2 patients in the last 5 days, for example, in SELECT2. So both of them using Viz.AI. So I really do think this is the future of acute ischemic stroke care, and I appreciate the audience. Thank you very much.